All right, and let's get the show started. Let me just make sure I'm on camera. Let me just tip this back a little bit. So we're good to go, and welcome to Back Talking, the show where we discuss all things related to the back or spine. I'm Todd Wegerski, and I am the host of the show. So this is our fourth episode on Blab. So getting better, tweaking things from week to week. Still have a few things I want to try out, and we'll probably do that next week when I get into trying Manicam. So we're moving forward. So maybe some of you people are finding me for the first time and are wondering just who I am. And again, my name is Todd Wegerski. I'm a doctor of chiropractic, and I'm also an acupuncturist. And I've been in practice since 1997. So I'm entering my 19th year of being in practice, but throw in studying and learning about backs with school, and it's been over 20 years. And I also have degrees in industrial engineering, and I did that before becoming a chiropractor, so I'm a real science nerd. So the advantage of the Back Talking show, what I feel, is that you get me, a real live person who has spent the past 20 years helping people with back pain. This is what I do. And I'm speaking to you from one of my treatment rooms. Just finished the morning session, just barely made it on the air. It's been a little crazy. So again, this is what I do. So you get to interact with me weekly on these live shows. So the show is my way to help those who are having back problems and are having questions and are seeking answers about their troubles. So the format of the Blab episodes are what I'm calling Spinal Grand Rounds, where I present a real life case to you. This is somebody's journey and their story. These are real people that have walked through my door. So you can follow along and maybe see the similarities between what you or someone that you know are dealing with. It's also very educational, and it's meant to be that way. You can never have too much information about your back. Now, last week we talked about Jessica, the 17-year-old volleyball player who is dealing with spondylolisthesis. And if you missed that, you can check it out at our website, backtalkinghelp.com. It's located under the video shows tab on the home page. You can also find the audio to that on the podcast, which can also be found on iTunes or Stitcher, and it's called Back Talking again. And as always, let me swing this around. You can find me. Let me get my TV on. There's two ways you can find me, and I'd like to hear from you. Please, you can send me an email. Here is my email address, todd@backtalkinghelp.com. Again, todd@backtalkinghelp.com. And here's my phone number as well, 919-439-4360. You can send me an email. Text me, call me, let me know what you're dealing with, and I'd like to help. All right, so on to our Spinal Grand Rounds case of the day. Today we're going to talk about Sheila. She's a 54-year-old woman. She works in the human resources department at an engineering firm just down the road from me. She's not a particularly active person. She doesn't belong to a health club. She's not an outdoors person anymore. She's more of the stay-at-home type. She's active in her church, and she goes there every Wednesday and Sunday. That is the extent of her social life. And she likes to knit. She says that probably up to 2 to 3 hours a night, she's knitting. She grew up in a small town in eastern North Carolina. She spent her youth in the tobacco fields, tending to the fields and harvesting the tobacco leaf. Now, she's always had a desk job, and for years she has had lower back pain, and she attributes it to all the hard work she did in her youth. But over the past 6 months, it has become much more noticeable. The pain just stays in her lower back. She doesn't have any leg symptoms at all, and as the day goes on, the pain becomes more intense. But it's not too bad. You know, on a scale of 1 to 10, it's probably a 4. But at night when she's knitting, she likes to place a heating pad on her lower back for hours. And then before bed, she likes to take a bath and soak in a hot tub to help soothe her aches and pains. All right. Now her exam findings. Sheila is about 5'4" and weighs in at about 190 pounds. Her posture is poor. She slumps forward and she pokes her head out, and she sticks her chin out as well. Now she points across the top of her butt as the painful site. And then she states that the pain runs up her back towards her head. Now she says that the pain is pretty equal on both sides. Now her active lumbar spine ranges of motion are limited in both flexion and extension directions. Her orthoneuro tests are rather vague, and they don't really help pinpoint the cause of her pain. Now her lumbar paraspinal muscles are very tender, sore, and achy. So I turn to the SFMA. What's going on here that we kind of lost focus? There we go. Lost focus there on the TV. So I turn to the SFMA, which is a screening test, which allows us to essentially examine all her joints and see how well she moves. And I'd look for any dysfunctional movements, asymmetries, or imbalances from one side to the other. And from this, we discern that she has ankle, hip, and of course, lumbar spine flexibility issues. I hope you got all that. Jumped ahead of myself. So before we can devote any effort to correcting her movement patterns or movement problems, we have to address her pain, because pain changes everything. Now, your body will create new movement patterns to avoid pain in order to protect the damaged tissues. So we begin treatment aimed at helping to reduce her symptoms. So she has pain at her L5, S1, and above. So we focus there. We choose electrical stimulation to reduce muscle spasms and in her lower back. We do manual therapy and myofascial release in an attempt to remove the stagnant blood and its associated waste products out of her muscles. Now, in chiropractic manipulation directed at L5S1 to provide movement at that segment. Now, what is part of pretty much everybody's therapy here is what I call learning to protect you from you. Simple, everyday tasks can irritate and typically are the cause of somebody's troubles. So getting out of bed, out of a chair, out of your car, off the toilet, or standing at the sink, brushing your teeth or shaving. These are all activities that are typically problematic for somebody with back pain. So we teach spine-sparing techniques to her. The principles of the hip hinge and abdominal stiffness were demonstrated to her. And also, no more heating pad. That's one of the worst things that she could do to herself. So now as her treatment progressed, I knew that she wasn't a very compliant patient. So, how do I know this? Because, I asked her to demonstrate various tasks and she couldn't. She continued to display poor control and continued to irritate her tissues. So what I want you to get out of this is that, the best clinician in the whole world can't help a patient if they can't remove the cause of a problem. So after several weeks of treatment, she would say that she felt great when she left, but it was short-lived. And the pain would start to return the following day. So I sent her for X-rays to make sure that there was really nothing else going on. The X-ray study revealed minor degenerative changes at L5S1 with anterior body osteophytes and facet joint sclerosis which is indicative of arthritic change at L4, 5, and L5S1. Now, she had been to her primary care physician because she has elevated cholesterol and is on a statin drug. Now, with the statins, you need periodic blood tests to make sure that it's not wrecking your liver. You know, what a great side effect of taking a statin. Now, when she was there, she mentioned to her primary care physician that her lower back was giving her pain. So he went ahead and ordered an MRI of her lower back. Now, these were the results of her MRI, and I'm just paraphrasing the results. So she had a lumbar spine MRI without contrast. It showed degenerative disc disease, or DDD, present at the L5 disc with loss of signal. She had an annular tear indicated by an area of high signal in the L5 disc consistent with a radial tear. And we'll come back to that in a little bit. And also the arthritic changes were, noted at the L4 as we saw L4, L5, and L5S1 as we found out in the X-ray before. Now it's time for the educational part of our show. So now each disc, here's a slide of a disc. Here's another one. We'll dig into these. Now each disc is comprised of two components. The outer layer is the annulus fibrosus, and the inner layer is the nucleus pulposus. Now the annulus is made up of about 15 to 20 concentric layers of collagen fibers that encircle the inner nucleus. So you can see about 15 to 20 fibers that run around and encircle the nucleus. Now, every other layer runs obliquely to each other. You can see it on this image right here. What I mean by oblique, that they kind of crisscross. So you can see this outer layer, it's called a lamella. The fibers run in this direction. The next layer in, they run the opposite direction. Now, this is a brilliant part of the design. So when we twist, half the layers are under tension and the other half relax. And then the opposite happens in the other direction. So the annulus, these fibers grow from one vertebra to another, and they attach themselves to the vertebra with what's called Sharpie's fibers. It literally grows into the bone. So there's no way for a disc to slip as we typically hear about. And the outer 1/3 of the annulus has a nerve supply, and it is pain sensitive. Now the inner part is, the nucleus pulposus is comprised of several substances, the most important being proteoglycans. And it has a gel-like, almost a toothpaste consistency. And its job is to help distribute the compressive forces across, the vertebra over a greater surface area. Now, the vertebra have a very rich blood supply. The disc has no blood supply whatsoever. So the disc relies upon glucose and oxygen and water kind of passively moving through the vertebra into the disc. It's a very inefficient method, but it works. Now, in this next slide, again, I just want you to take notice of this side over here. So with the nucleus, when it's under compression, the nucleus is that toothpaste material. It forces the annulus to be under tension. So this keeps the disc, this is nice and healthy right here, under tension. The annular fibers are kind of compressed together and everybody's happy. So now, what is degenerative disc disease? It's extremely common, and it's encountered with increasing frequency as we age. And it's almost synonymous with the aging process. And it's now considered part of the normal aging process. The highest risk factor for acquiring degenerative disc disease is genetics, being dealt a bad hand from the family tree. And as we discussed earlier, it is the genes that say how proteoglycans that make up the nucleus pulposus are made. With good genes, we get healthy proteoglycans, which then attract glucose, oxygen, and water and help to support cell metabolism. Now, biomechanical loading, which was once thought to be the number one cause, has fallen to number two. This is when the disc is under consistent, extreme compressive loads, either from, say, heavy manual labor or even sitting slumped in a chair, puts high compressive loads on the disc, causing it to break down and die. Now, the medical professions we're slowly moving away from using the term tear because it almost has a traumatic implication. The proper word now is fissure. So instead of annular tear, we now call it an annular fissure. So a tear or a fissure is a deficiency in one or more layers of the collagen that makes up the annulus. It can be either concentric, meaning it's between the layers in this direction, or radial, where the lesion is through the layers, and these begin and occur from the inside out. So in this image right here, we see a radial tear. This is between the layers going from the inside out. A concentric tear would be this way, up and down in between the layers. Now, how do these present? Most of these are asymptomatic, and they're not detected on MRI or any other imaging methods. Others are quite painful. I'm talking significant pain, up 8, 9, 10 out of 10 levels. And these are very painful when they leak fluid, which irritates the local nerves. And we'll see a picture of that in a little bit. But because they appear in both symptomatic and asymptomatic individuals and patients, it's hard to determine whether it's just an incidental finding or the true cause of pain. All right, so here is a T2 weighted MRI image on the left. Now on T2 images, any structure that is high in water content glows bright white. We see the fat planes here here's the back. This is the person's back. Their stomach would be up here. Here's fat around their back. Here's fat in their abdominal viscera. This is very white. We see the vertebral canal through here, the cerebral spinal fluid, which has a high water content. This glows extremely white. And then when we look at discs, the center of the disc, the nucleus pulposus, has a high water content. And you can see it's nice and white. Now, when we come down here to L5, it's dark. It has lost this signal, the white signal. This means that it has lost its water content. It's beginning to degenerate. It's beginning to die. Now, in the posterior aspect here of the L5 disc, you see this white little blob, this white line. This is a tear. This is a tear in the disc. And you can see it on the T1 image as well. Shows up nice, glowing white right here. Now, this is what I was talking about with a disc that is leaking. We get the fluid, which is kind of leaches through the vertebra into the disc and accumulates in the disc. It's almost like water running through sand. The sand is the sieve, and it accumulates here. Now, this fluid isn't typically present, and this will irritate any of the local nerves. Like I was saying earlier, the outer third of the annulus has a nerve supply and is very pain sensitive. So this fluid can light up that nerve, or if it's close to one of the spinal nerve roots, it will give you pain. Now, how do you treat this? Annular disc tears or fissures can typically be treated conservatively with ice, massage therapy, manipulation, and such. The most important thing to remember with disc injuries is that they take time. Because they don't have a blood supply that can quickly get the materials there to help it repair itself. It is a slow process. It can take 6 to 18 months. And people, they grow impatient. And I'm constantly having to remind patients of the long-term benefits of doing the work now. I know it hurts, but think in the long run, this is going to be best for you to do the therapy, to do your exercises. But most importantly, we have to teach them lifestyle modifications. We teach people how to move so that they don't continue to hurt themselves over and over and over again. I can't put a body cast on you to protect that area. So we have to use what I talked about earlier, the hip hinge and the abdominal brace to protect ourselves. And finally, putting in the work with exercises aimed at building up your endurance. Endurance is the key. Strength gains are secondary, but we need to work at building up the endurance of your muscles. The strength will come, and also working on your cardiovascular fitness. So it's Q&A time. And I'm looking over to my screen and I don't see anybody asking any questions. So this was just a good primer. Every version here is educational. I'm starting to talk about the disc. You're going to hear it ad nauseum, the annulus, the nucleus, disc health, how discs go bad. And we're finding out genetics is the number one cause of disc degeneration, just the cards you are dealt. So that kind of stinks. I'm just going to jump over to the next slide. So have a topic. I'd like to hear from you for anything you want to talk about. Of course, everything is kept anonymous. Nobody will find out who you are. Everybody's name is changed to protect the innocent, as they say. Reach out to me, todd@backtalkinghelp.com. Again, it's todd@backtalkinghelp.com. And next week, February 5th at 1 o'clock, we're going to dig into lumbar sprain, strain type injuries. And here I am. Let me come back around. And thanks for joining me today. Again, I'm Todd Wegerski. You can find my podcast, Back Talking, on Stitcher and iTunes, or go to the website, backtalkinghelp.com. There's a lot of information out there to help you with your back. So thanks, everybody, and I'll see you next time.